can I get some? I just checked my speaker. It's working. Yeah. So stop. Testing, 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 testing. 4 score and 7 years ago, blah, blah, blah. Okay. Okay. Hey, Bree, can you hear me?
Yes, I can.
And do the slides move?
Yep.
Okay. Oh. Poor. Yeah, should we build an ark? Oops. That's better.
I was like, if you please do something. If you don't go back, oh, girl. You got at the worst. Yeah, right or wrong. It's starting to hail. Hey, so things.
Yeah, it looks like it's stopped now. And there's Luke Ornhill, who's wearing shorts. There you go. Where you going, Luke? That guy's metabolism is so high. Probably sweats while it's snowing out there. Ooh, skeleton crew today. Well, we have some people who are ill, so that's why I sent the Zoom link. Well, I've been reading over your focus series reflections, and some of you didn't like some of the speakers, but you seem afraid to say so. You didn't like a speaker, it's okay to say you didn't like the speaker. You didn't like the presentation, that's quite all right. So if you didn't like a presentation, you either disagreed with them or you thought the presentation just really didn't teach you very much, just say so. You don't need to be so diplomatic with me. Yeah, I'm not gonna show your paper to the people who gave the speech. It's your secret is safe with me. So if you didn't like any of them, please feel free to say so. If you didn't like them, please feel free to say so. Some of you are trying to be very diplomatic. As though being diplomatic is part of your grade. No, I want to know what you think. I'm interested in what you think about this because Tom is going to, Dr. Posey-Fried is going to ask me, what did your students think? How can we improve things? What sort of topics weren't covered in the workshops that they would like to have seen covered? So that type of feedback can be very useful for me. So, because that's what I'll pass on to Tom when he asks me. So feel free to just be painfully honest. Having said that, some of your thoughts were, I thought, nicely put. So glad you guys went. I'm glad you guys seem to have learned something. So, well, looks like it's essentially time. So by way of review, we have two main types of polyps, abnormal growths in the colon. We have those that are invasive and those that are not. And there are several genetic conditions that increase the risk of having invasive colorectal carcinoma. So the two main ones are Lynch syndrome. Lynch syndrome results typically from mutations in genes that encode proteins involved in mismatch repair. Mismatch repair. You have two bases and they are poorly matched. There's a structural difference in the DNA. The helix is not regular anymore. The mismatch repair comes in, it clips out a section with the errant bases and it repairs them. And then familial adenomatous polyposis, FAP. We'll talk about that one after we talk about Lynch syndrome. That has a different clinical presentation. So the familial adenomatosis, adenomatous polyposis, that presents as an autosomal recessive. Same thing with Lynch syndrome, that also is inherited as an autosomal recessive. Now, if you are heterozygous for these mutations, you can have mutations arise in the gut because the GI tract is one of those parts of your body that gets displaced very quickly. So the mitotic index of those cells is very high. Consequently, you have lots of opportunities for mutations in the other copy to arise. Therefore, you can have variants that arise that will essentially cause sections of the colon that become tumors. So you have, therefore, high likelihood of developing colorectal carcinoma as a carrier of either Lynch syndrome or FAP, familial adenomatous polyposis. Let's talk about Lynch syndrome first. This will predominantly affect the right side of the colon. We talked about the presentation difference. If you have tumors on the right or the left side, to review, help review this with me. On the left side, the tumor will tend to invade the wall of the colon. It will also tend to obstruct the colon, so the clinical presentation tends to be what?
Usually it's more of a
Right, constipation, obstruction. You tend to have, your stools tend to be really narrowed and what have you. On the right side, the presentation is.
This is a mass.
Right, you get a mass that tends to go in to the lumen of the colon. They don't tend to cause obstruction, they do tend to bleed. So your clinical presentation is usually lactose stools, and the other one is, there you go, IDA, iron deficiency anemia. Good job, Kevin, good job. All right, so this is going to tend to cause right-sided. So if it's right-sided, it'll tend to be the IDA, iron deficiency anemia. You don't get many polyps, but the polyps that you get show very rapid transformation. They can go from a regular small polyp to an adenoma in about 35 months. That's about a year and a half, essentially. Very fast, because they have that defect in DNA repair. So the mean age for sporadic Colorectal carcinomas by 48 years of age. When you have Lynch syndrome, you get sporadic colorectal carcinoma rising significantly earlier, 10 to 15 years earlier. You're also at risk for other cancer and other tissues that show a high mitotic index. Tissues like the endometrium, tissues like the stomach, the ovary, the pancreas, particularly the ductal system, the urinary tract, small intestine, biliary tract, and then brain cancer as well. Neurons don't show high mitotic index, but certain other cells in the brain have a higher mitotic index. There are very good screens for Lynch syndrome that are commercially available. You also see something called microsatellite instability. Microsatellite instability is relatively easy to test for. So we said microsatellites are these AT-rich sequences. They're 5 to 12 bases in length, and they're repeated hundreds of thousands of times. And by using PCR, you can detect how many times they're repeated using something called real-time PCR. These sequences, by the way, are not expressed. They're not expressed. By detecting the number of these microsatellites and seeing how much they vary within cells in a biopsy, that tells you you have microsatellite instability. That's a hallmark of Lynch syndrome. So families should be recommended for genetic counseling. They should be genetically screened with the proper tests. Insurance usually will pay for this if it's recommended by your healthcare provider to get these tests. The answer down rule, which is very much like the Bethesda rule, 3-2-1, 3 affected members, 2 generations, and 1 generation, those who had colorectal carcinoma at an age of younger than 50 years old. Those who are removed from you 2 generations, those removed from you 1 generation. 3-2-1 if you have the 3 people, either remove 2 or 1, who had cancer younger than 50 years old. That meets the Amsterdam and Bethesda criteria for screening. Once you document a mutation in genes that are known to cause Lynch syndrome when they are mutagenized, then you're going to have colonoscopies every 1 to 2 years. You're going to start at 25 years old or 5 to 10 years younger than the age at diagnosis of the youngest affected family, whichever is first. You also have EGDs every 2 to 3 years to screen for gastric cancer, and in women starting at age 20 to 25, 35, you should have pelvic examinations, carcinoma antigen 125 assays, pretty easy test to do, endometrial aspirations, transvaginal ultrasound sorts of screenings, and you should have those yearly. And then it's recommended you have a prophylactic hysterectomy after you've had your kids, if you want kids. Any questions about Lynch syndrome before we move on? FAP is inherited as an autosomal dominant. In this case, you have lots of polyps all over the colon. So with Lynch syndrome, you don't get more polyps, but the polyps you get tend to transform very quickly. Here, you have hundreds and hundreds of polyps that fill the colon. So you first see this during your teenage years, usually. You'll usually detect this with a colonoscopy. And people with FAP, they have mutations in this APC gene. They have a 100% chance of developing colorectal carcinoma from these polyps by age 45. They usually get colorectal carcinoma earlier than that. There are variants of familial adenomatous polyposis. They're called Gardner syndrome, and then MAP, which we'll talk about here in just a bit. So the attenuated FAP, you have polyps in the colon, but they're not hundreds. You can count them. It's more like tens. So you have a later average onset of colorectal carcinoma. This is still serious. This is still something you need to watch. Gardner syndrome, you have a tendency to have extracolonic manifestations. You have these other issues, bumps on the bones of the legs, arms, skull, jaw. You get these cysts in your skin. You have teeth that show malformation. You have freckle-like spots on the inside of the eyes, eyelids, and what have you. It's very odd. You essentially have mutations in addition to the APC mutation, or you have a different mutation that also increases your risk of colorectal carcinoma with these other problems. The MUth-associated polyposis is due to mutations in the MUth gene. The MUth gene encodes a protein involved with something called base excision repair. With base excision repair, you have an errant base, and there's an enzyme that's called a DNA glycosylase. It comes up and it clips the bond between the ribose and the base. And now you have a sugar that doesn't have a base. So there's an enzyme called an AP nuclease that just clips out that sugar, and then a polymerase comes in, puts in the right base, and then ligase will seal the nick and the backbone of the DNA. That's what you do for single errant bases. Usually when you have a base that's gone awry, they tend to appear in groups, but if you have just one bad base excision repair is very active. One of those glycosolases, those DNA glycosolases, is encoded by the MUth gene. And so mutations in the MUth gene can cause a variant of familial adenomatous polyposis. See, once again, you have defects in DNA repair. Those defects in DNA repair cause cancer. So you have a lifetime colorectal carcinoma risk of 70–75%. This can appear spontaneously, so you might not have a family history of this. Might be spontaneous, so you might all of a sudden get multiple colorectal adenomas, and there's no family history of it. It might be MUth associated. There are good tests for this condition as well. So with familial adenomatous polyposis, you have mutations in this gene that's on chromosome 5, adenomatous polyposis chole APC. This particular protein is involved with a signal transduction pathway called the Wnt pathway. Now, the Wnt pathway is near and dear to my heart because as a postdoc, this is the pathway I worked on for my research. I was looking at Wnt signaling in the peripheral nervous system, the development of the peripheral nervous system in my work. So this is a pathway that very near and dear to my heart. But it turns out the Wnt pathway regulates growth, healing, and cell proliferation in the gastrointestinal tract. APC, the protein, downregulates the Wnt pathway, so it keeps the Wnt pathway in check. So it has the Wnt pathway working in that Goldilocks zone, not too hot, not too cold. When the APC essentially keeps it from not too hot. When APC is inactivated by mutations, Now the Wnt pathway runs too hot, and cells start dividing uncontrollably. And so with mutations in APC, you start to get a colon filled with these small little polyps. This is what it looks like, essentially. Better. See all the little polyps? Instead of the smooth lining, you see something that looks like corrugated cardboard that has been chewed on by a rat, essentially. So now, notice you can't count those. There's untold thousands of them. So you're the nurse. This is the report that comes in. What do you think this patient's going to need, essentially, to prevent them? They're guaranteed colorectal carcinoma. Guaranteed. What do you think is going to need to be done? You ever grab your ankles and kiss it goodbye, or is there something else that can be done for it?
Can you like remove part of the colon?
You can take the colon out, yeah. You can take the colon out. And that's usually what's done for these people, a colectomy, a prophylactic colectomy. Because essentially they've got a ticking time bomb in their colon. Take the colon out, they have risk, they're at risk of cancer in other tissues. They're not nearly as at high risk as they are in the colon. All right, so genetic counseling should be offered to any patient that has 10 or more adenomas identified in their colonoscopy. It should also be offered to any first-degree relatives of that particular patient. Very good commercial tests for APC that are available. And if you have 10 or more adenomas, even if they're small adenomas like that, the insurance almost always pays for it. There are also good tests for the MUF gene. So if the patient is negative for mutations in APC, the tests available for APC aren't perfect, but they're pretty good. You're usually not going to miss mutations in APC. You can test for MUF as well. Usually, patients who have excess number of adenomas like that in their colon, you'll have usually a panel that's tested, and it will include MUF and APC. Children of patients with familial adenomatous polyposis, they'll undergo screening starting age 10. And then first-degree relatives, they should undergo yearly colonoscopy starting at age 12. Not a very pleasant thing for a 12-year-old to go through, but it needs to be done. And usually before the age of 20, it's recommended that they have a proctocolectomy or a colectomy. They also need to have the upper GI evaluated every 1 to 3 years, so an EGD. They're also at higher risk for thyroid cancer, so they should have thyroid ultrasounds as well. In attenuated familial adenomatous polyposis, you screen every 1 to 3 years and you start at age 15. And with attenuated familial adenomatous polyposis, you should use colonoscopy for screening just because it's easier to miss these types of polyps. You're more likely to miss them if you use a flexible sigmoidoscopy. Most gastroenterologists are very well aware of that. Questions about familial adenomatous polyposis? FAP tends to appear more commonly in people of European descent. That's where you tend to see it usually. Peutz-Jeghers syndrome. We saw this in breast cancer. But Peutz-Jeghers syndrome is due to mutations in that kinase called STK11. So this is autosomal dominant. It tends to cause hematomatous polyps. Remember, those are not invasive, but they can become invasive. Median age presentation is about 11 years old. These polyps, they occur also throughout the stomach and small intestine. They increase the risk for intussusception. Remember what intussusception is? Where the intestine does that. So this gets stuck in telescopes essentially, and like that. This area then becomes ischemic because it's being cinched down on the blood supply to that area. Now it gets stopped, and so that area starts to necrose and die. And that's the medical emergency. So people with Peutz-Jeghers syndrome have increased risks of intussusception. So this condition is associated with an increased risk, gastric cancers, small intestinal colonic malignancies, also breast and ovarian cancer as well. Here's an example of one of those masses. You can see this is obstructing the colon. So this is obviously a left to right, left side colonic presentation, which clinically will present with constipation, hematochezia, melena, things like that. Also, you tend to see the dark spots inside the mouth. You see those? When you see dark spots on the lips and inside the mouth like that, that should give you pause. In fact, that presentation right there is enough to justify having someone screened for Peutz-Jeghers syndrome. Questions? All right, so to summarize what we've talked about, your colorectal carcinoma starts out with cells that are hyperplastic. They're growing faster than other cells. They're not yet tumorous, they're not yet invasive, but they're growing faster than everything else. If they have mutations in other genes, those other mutations can cause them to increase, to grow even faster and to leave their tissue of origin and invade other tissues, become malignant. Certain mutations that you inherit from your parents can increase the risk of colorectal carcinoma. These genetic causes, there are two of them that are autosomal dominant: Lynch syndrome and familial adenomatous polyposis. Those have been properly identified. And genetic counseling and testing should be offered to individuals suspected of Lynch syndrome. Counseling should be offered to those with 20 or more adenomas identified in colonoscopy. They should be screened for familial adenomatous polyposis. And with Lynch syndrome or FAP, screening should be done with colonoscopy rather than flexible sigmoidoscopy, just because the polyps don't show even distribution throughout the colon, and they can be easy to miss. And here are some resources if you are interested. Questions on any or all of that?
So is it only up to that chapter that we're testing over?
By that chapter, you mean chapter 8? Yes, that's correct. Oh, and I should, I need to do this. I'm going to open a discussion board and you guys can compose questions for me. I did that for my farm class, the other farm class I teach, and it worked quite well. So that way you guys can all see the questions and makes writing the test a lot easier too. And as I've said before, I like easy. Very good. Any more questions on colon cancer? Does anyone here have colon cancer that's affected your family or friends of yours or anyone? Yeah. Colon cancer, fortunately, is very treatable if you treat it early. That's why colonoscopy saves lives. You should get your colonoscopies. You're asleep for the whole thing. You won't remember it. The hardest part is the prep. And the prep's gotten easier and easier. Prep used to take 3 days. Now it just takes 1 day. So. Leukemia. So leukemia comes in 2 main types. So there's chronic myelogenous leukemia. Chronic leukemia, excuse me, comes in 2 types. There's acute leukemias as well. So there's chronic myelogenous leukemia and chronic lymphocytic leukemia. Those 2 types of leukemias are very different. The genetics of chronic myelogenous leukemia tends to be very homogeneous. The genetics of chronic lymphocytic leukemia is very heterogeneous. So it's very hard to just nail down this particular change causes CLL. No, there's lots of different genetic changes that can cause CLL. Whereas with chronic myelogenous leukemia, it's associated with the creation of the so-called Philadelphia chromosome. So the goal here is to give you an overview essentially of leukemia, chronic myelogenous leukemia at least. So where do blood cells come from? Yes, the bone marrow. In the bone marrow, you have cells called hematopoietic stem cells that make all the blood cells in your body. And these cells will divide. One of those cells will stay a stem cell. The other cell will go down the lymphoid lineage, and the lymphoid lineage is going to make either B lymphocytes, or it's going to make T lymphocytes, or it's going to make natural killer cells. Those are all the cells of the lymphoid lineage. The other lineage is the myelogenous or the myeloid lineage. Now, the myeloid lineage includes a erythroid lineage that consists of red blood cells. There's also a granulocytic, and it makes granulocytes, and the granulocytes consist of things like neutrophils and basophils and eosinophils. And there are the agranulocytic. And these will be mainly your monocytes. And then also there is the thrombocytic lineage, the so-called megakaryocytes. And megakaryocytes, they will bud off their cytoplasm and they will make platelets. This whole thing is driven by cytokines in the bone marrow that drive these progenitors into one lineage or another. Your body makes those cytokines in response to need. So the erythroid lineage is driven by erythropoietin. What organ makes erythropoietin in your body? Sorry? No, not the spleen, nor the liver, but spleen and livers do make other cytokines, just not that one. Kidneys. That's why chronic kidney failure can start causing anemia. So erythropoietin drives the myeloid lineage into the erythroid line. When it comes to the granulocytes, genes that drive the growth and proliferation and differentiation into granulocytes can get stuck in the on state. And so now you start making cells that proliferate into this particular stage and they get stuck. They don't really ever mature into fully mature granulocytes. So you overproduce these myeloid lineage cells. And this can be either acute or chronic. The acute forms are usually more aggressive than the chronic. In the acute form, usually your cells are very immature. In the chronic stage, the cells are usually not quite as immature, but they're not completely mature. Chronic myelogenous leukemia usually progresses slowly. Acute myelogenous leukemia is usually the onset is quite rapid. So CML is also called chronic myelogenous leukemia, chronic myelocytic leukemia, or chronic granulocytic leukemia. You see those terms, they're all the same thing. Kind of like tricarboxylic acid cycle, citric acid cycle, Krebs cycle. They're all the same thing. It's the same cycle, just different names. This thing, same disease, just different names. So this is in all caps because I really want you to know it. So it causes an uncontrolled proliferation, uncontrolled production of the granulocytic cell line. Granulocytic cell line. You should wake up in the morning. You should look at yourself in the mirror. You should start to comb your hair and say, chronic myelogenous leukemia is caused by overproduction of cells in the granulocytic lineage. You should say that to yourself several times every morning when you get up and you will never forget, especially when it comes time for the test. So these immature granulocytes fill the bone marrow, they spill out into the peripheral blood. They're morphologically normal, but they're usually either not functional or they're subfunctional. The majority of those abnormal cells usually are neutrophils, but the other granulocytes are also affected, but not as much as the neutrophils. That is a feature of chronic myelogenous leukemia. Okay, pause, questions? With me so far? Very good. So the onset of chronic myelogenous leukemia is slow and insidious. And patients usually are asymptomatic. When they come back from their physical and they get their readout from their physical, usually the blood is dropped into a machine. The machine will tell you that you got way too many neutrophils. Now that might indicate that you had an infection. But usually then you'll be sent to a hematologist who will draw some blood and look at it themselves and then look at some molecular markers. And when they get the readout that they have chronic myelogenous leukemia, the patient may say, well, I feel fine. They probably do. But as that burden of abnormal cells increases, those cells are now going to use up all the resources that the healthy cells, functioning cells, need. So you have a decrease in the number of healthy cells. So that is called a blast crisis. The blast crisis occurs quite early in people with acute leukemia, but you'll start to be prone to infections. You'll have anemia, and because of the lack of platelets, what do we call lack of platelets? Let's start with that. Say again, Caitlin, say it louder. Yeah. No, say it with confidence, you're right. Yeah, thrombocytopenia, good job. So thrombocytopenia, anemia, infections because of thrombocytopenia, they may be flossing their teeth or something, and the teeth start to bleed and they won't stop bleeding. Then they go to the dentist, and the hygienist is cleaning their gums. They may start to bleed and they just won't stop bleeding. So there are 1 to 2 cases per 100,000 of these in the US, so 4 to 10,000 cases annually. Median age is 55. Males tend to get this more often than female. The only known predisposing factor is exposure to ionizing radiation, but plenty of people who haven't had much exposure to ionizing radiation get chronic myelogenous leukemia as well. So half the patients, one diagnosis, have no symptoms. And usually you'll have something like over 100,000 white blood cells, most of those granulocytes, neutrophils, on a complete blood count. Symptomatic patients will have very typical leukemia symptoms: fatigue, unexplained weight loss, fever, night sweats. The spleen will be involved, so the spleen gets bigger. So on the upper left quadrant, there may be some fullness, some pain and discomfort, bleeding episodes, and then tenderness of the lower sternum as the bone marrow starts to overextend. Am I going too fast? No? Let's talk about chronic myelogenous leukemia genetics. So CML results from a translocation between chromosomes 9 and chromosome 22. This translocation takes 2 proto-oncogenes and fuses them together. So you get a gene fusion between the BCR gene and the Abel tyrosine kinase. The Abel tyrosine kinase, because it's been fused in frame to the BCR gene, is now unregulated, and so it drives unregulated cell growth and division. This is a mutation that is not found in the germline. It will be found in the leukemic cells. 90 to 95% of patients with chronic myelogenous leukemia, which is to say almost all of them, have the Philadelphia chromosome. Patients without the Philadelphia chromosome have some sort of other translocation that usually encodes some sort of BCR-Abel fusion protein. So here's what it looks like in a cartoon. Chromosome 9, as you can see, is a long chromosome. You have a break at the tip of the chromosome. Chromosome 22, you have a break up to, close to the centromere. You then have a swap, a reciprocal translocation. This piece gets swapped to there, that piece gets swapped to there. So you have a new chromosome 9 on chromosome 22. You now have the BCR-ABL gene fusion. That new chromosome 22 is called the Philadelphia chromosome. This is what it looks like on a chromosome smear. Here's your new chromosome 9 with that piece of chromosome 22. Here's your new chromosome 22. Chromosome 22 is way too big. And that's one of the tip-offs. Chromosome 9 is too long, chromosome 22 is too big. And notice there's the other homolog. You put these two together. That's that old song from Sesame Street. One of these is not like the other. One of these is not like the other. And one of those is not like the other. 22. So this is a reciprocal translocation. Reciprocal translocation. Question, Katie? No? Yeah, that picture is easier to make sense of than that one probably, but yeah.
When you say it's too big, like what, like that's too long?
It's too long.
It should look like a dot then?
Not a dot, no. Chromosome 22 normally looks about that big there. So this bit here, I should be there. It's too long. I'm not a human cytogenetics expert. I've looked at my fair share of these. I looked at tens of them. I haven't looked at thousands of them. People who do this for a living have looked at thousands of them. They can just look at it. Oh, yep, there it is. I'm not that good. So if you're it's suspected that you have chronic myelogenous leukemia, you need a bone marrow biopsy. So you either tap the sternum or you get it from the crest of the ilium. You then have a karyotype. The karyotype can tell you if you have the oddball chromosomes. It can't tell you if you have a BCR-ABL fusion. You need to do FISH for that. FISH will identify that you have a BCR-ABL fusion. Quantitative PCR can tell you how much transcript you have, so-called qPCR. So the chronic phase, where you're less than 10% of your cells consist of blast cells, that will usually last 2 to 4 years. The accelerated phase varies as to how long it lasts. In this case, your blast cells go from 10 to about 19%. And then the blastic stage, now more than 20% of your blood cells are blast cells. In the blastic stage, your median survival is less than 4 months. And at the blastic stage, you'll have fatigue, fever, and an enlarged spleen. Now, here's the good news about chronic myelogenous leukemia. The BCR-ABL protein is a new protein. It's not found in non-cancerous cells, is it? You shake your head, no, it's not. It's novel to those cancer cells. So drug companies took the BCR-ABL protein and they looked for small molecules that specifically inhibited BCR-ABL. And they came up with this drug, imatinib, trade name, Gleevec. Gleevec. Gleevec is remarkably well tolerated. And people, this is a so-called targeted kinase inhibitor, TKI. And the tyrosine, targeted tyrosine kinase inhibitors, they inhibit BCR-ABL, they decrease the blast cells, and they induce programmed cell death in those cells. Patients have been on imatinib for years. Some have been on it even for decades. Now, there are cells that can undergo mutations. Their mutations allow them to escape inhibition by imatinib. Drug companies have examined that too. They have alternative drugs that can inhibit those rogue versions of BCR-ABL that escape inhibition by imatinib. So you can transition someone from imatinib to dasatinib, or from dasatinib to nilotinib. And now there are some new drugs as well called bosutinib, and then another called ponatinib. And these drugs, essentially, if one doesn't work, you transition them to the other. Again, quite well tolerated. And people can be on them for years, and these will usually keep chronic myelogenous leukemia at bay. Now, to cure it, you need a bone marrow transplant. But because most people who get this disease tend to be older, a bone marrow transplant will almost certainly kill it. So the TKIs really are the treatment of choice. So to evaluate the response to treatment, you look at the blood. What do you want to see in the blood if the imatinib is working? Right, the blast cells. Those blast cells, their percentage of total blood should be heading south, should be decreasing. That's what I mean by heading south, should be decreasing. Cytogenic response, when you look in the bone marrow for cells with the Philadelphia chromosome, there should be fewer of them. And then the molecular response, the amount of BCR-ABL transcript that you can measure by qPCR, that should be less too. When all three of these criteria are met, that tells you the drug is working.
The cytogenic response, it should be less of what?
The Philadelphia chromosome. When you do these spreads, you can do them on multiple cells at a time. And you get fields essentially in a microscope. In fact, the computer now can just go take pictures of some of the chromosomes, some of the chromosomes, some of the chromosomes, and then you just go look through them. Now they're AI programs. If you tell the AI what you're looking for, the AI will. In 105 fields, I found 72 of them that had this chromosome. In 110 fields, I found 30 of them that had this chromosome. Very cool. So with bone marrow transplants are offered provided you can find a match. Those are offered to people younger than 50 years old. You can also use umbilical cord blood. The problem with umbilical cord blood is you don't get as many stem cells in the umbilical cord blood because there's less of it. So you usually have to mix cord blood from people with different HLA types, but with cord blood, you are less likely to get rejection, immunological rejection, because of the immaturity of the cord blood cells. So cord blood has been used to treat people with CML, but it takes more of it. The risk, of course, with all stem cell transplants of this type is graft versus host response. What's graft versus host response? Who can tell me what that is? Also, it's the way the transplanted tissue reacts to you. So the bone marrow produces B and T cells. Those B and T cells might come into your body and say, this isn't home. And they might start attacking your tissue. So it's because typically your bone marrow is wiped out before the bone marrow is given to you. So it's usually the new bone marrow's immune cells attacking your tissue. This can usually be quelled with very aggressive immunosuppressants. It gets knocked down, and usually you can wean people off the drugs and it goes away. Graft rejection is a problem. Nowadays, with graft rejection, that's not nearly as common. With better screening, what have you, but it still happens. Now, if you're waiting for a definitive diagnosis, you can use this medication, hydroxyurea. Hydroxyurea will prevent the proliferation of the rogue cells. We're going to see hydroxyurea again because we're going to, one of the units is on sickle cell disease, and hydroxyurea is a drug that's used for sickle cell disease. So what's a prognosis? The disease can be well controlled by TKIs, and TKIs are oral, so they don't have to come in for infusions. They don't have to give themselves injections. Over 90% of patients are alive at 6 years. This is very different than chronic lymphocytic leukemia. So the factors that affect the prognosis, of course, are age, the phase of the chronic myelogenous leukemia, the types of cytogenetics, you have other mutations too that have occurred, and any comorbidities that the patient may have as well. So that is an example of a somatic mutation, one that is not inherited. The family history will usually not be very informative for chronic myelogenous leukemia. Very good. So to summarize, leukemia is a cancer, starts in the bone marrow, which is from the blood cells. You have a proliferation abnormality. You fill up with these immature granulocytes. It is a overproduction of cells of the granulocytic lineage. Too many of those cells develop into abnormal granulocytes, the major one being neutrophils. It's a really good orange. And because of that, they crowd out normal cells. They prevent the normal cells from doing their job. Genetically, this is caused by a reciprocal translocation between the long arms of chromosomes 9 and 22. 9 and 22. That causes a production of a fusion gene. You get a new oncogene that's made, BCR and ABL. ABL is a tyrosine kinase that regulates cell growth. When you make this fusion gene, the ABL kinase is now uninhibited and drives uncontrolled proliferation of these granulocytic lineage cells. You can treat it with TKIs, but the only proven curative for CML is a bone marrow transplant. Any questions about leukemia? That knock a little rust off from pathophys, maybe? Yes? No? Some of you, yeah. Didn't learn it that well in pathophys in the first place. So, yeah. We're done a little early, but I don't have any compunctions about letting you go early. Do you? Then please enjoy the weekend. It's supposed to be cold this weekend. It's supposed to snow tomorrow. But enjoy your weekend, and I will see you guys here Monday. Test is Friday, correct? I will need them by early Thursday. So I will write the test on Thursday. In fact, here. Okay, folks, that's all for today. So I'm going to sign off here.